Hi, and welcome to Healthy Living. I'm Dr. Donald Pelto, and I'm here with Dr. Camille Roberts. She is a dermatologist in the area of Worcester, and we're here to talk about her practice and some of her areas of interest. Camille, thank you for joining us here today.
Well, thank you for having me. It's a pleasure.
So today we're going to talk a little bit about kind of dermatology and how you kind of got interested in the profession of dermatology and what is some of the training like and things like that. So tell me, how did you get interested in dermatology to start with?
Yeah, I have to say initially entering medical school, I always knew I wanted to be a physician, but I loved dermatology probably starting my second year of medical school when I had a lecture given by one of the professors, and I sat there and it just spoke to me. I love the visual aspect of it. I like the procedures that they do. And so it was something that I thought, hey, this might be worth investigating. So I started by hanging out with the residents, which the hospital was right nearby. And that developed my interest. I did a couple of rotations towards the third and fourth year of my medical school training. I applied for the residency and luckily got in.
I was going to say, because they say dermatology is one of the more challenging areas to get into. That's what it is now? Is it?
Yeah, I guess that's what they say. But in life, if there's something you want, you have to go after it, and that's the way I felt. Despite all the odds probably being stacked against me, I thought, you know what, this is what I wanted. I went after it, and it worked out for me. So, encourage anyone, if it's just a life lesson.
If you're interested
in something, just go after it.
Right. And did you have to do an intern year of internal medicine and then a residency?
So we did 1 year. I did 1 year of general medicine at Washington Hospital Center prior to my 3 years of derm training at Howard University Hospital.
Great. And then during that time, what area, did you have to kind of get an area that you're interested in, or do you focus on everything?
So we basically focused on everything, primarily medical dermatology, so dealing with things like skin cancer, eczema, psoriasis, acne, but also we had exposure to the surgical aspects of dermatology, removing skin cancers and moles and what have you. And then also the cosmetic side of dermatology, which was really just starting back in the early, like I graduated residency in 2003. So lasers were just becoming very, very popular. So, we got the taste of pretty much everything.
And what's your current practice like today?
So my current practice is primarily medical dermatology. We also do a little cosmetic procedures. We do Botox and some fillers, but primarily medical derm, like acne, eczema, psoriasis, a lot of skin cancer. And so it's varied, and I see from babies all the way to people in their 80s and 90s and in between. We do several neat procedures. So, a typical day in my office is not predictable, and that's the way I like it.
That's nice. So it's a little bit different every day.
So it's a little bit different every day.
Yeah. And who typically, how do you get your patients? Are they referred from doctors, from referrals? How do your patients show up? Do they have to give a referral? That's always a question they give me.
So yes, usually most of our patients come from other physicians, primary care doctors, internists, or family medicine docs. A lot of them also come from word of mouth, whether through family members that have seen me or friends. I get, right now I have a few families that I see. I have families, people coming and saying, hey, you see my entire family, Dr. Roberts. So I like that, I have had patients see me for the last 13 years since I've been in the Worcester area. Yes, most people do need a referral, although it depends on the type of insurance that you have. So we encourage you to check with your insurance carrier.
Yeah, that's something we always say as well.
Yes.
So are a lot of the conditions that you see, if their parents have it, do the children have the same condition, or are they different conditions?
It varies. It varies. I mean, there are a few, fairly genetic things. There are a few genetic things in dermatology, and a few contagious things in dermatology. But I see, when I see, for example, husbands and wives, they come in for skin checks. A parent can come in for eczema and bring their child in for acne. So again, it just speaks to the unpredictability of dermatology. We treat it as we see it, and it can vary. So we really have a good time.
In a lot of, I remember when we were in school, we talked about dermatological things can be a masquerader. It may look like one thing, and if, for example, if I'm seeing something, I'll think it's an eczema or dermatitis, and it may be something totally different, like a fungus or something else like that. And they always kind of...
There are a few things that have similarities, like eczema and psoriasis you mentioned, or sometimes ringworm, which is actually tinea, which is a fungal infection, can look like eczema. But, you know, there are clues in the history, in the treatment options that patients have tried that tease it out. And also sometimes we can do biopsies to confirm certain diagnoses. So that's always helpful.
Yeah, I'm finding more and more patients these days, they're looking on the internet before they come and see us.
Sure.
And they look in Dr. Google, and they'll look, okay, here's what I have, let's see if I can find similar pictures, and they may try some treatments.
Sure.
But in the end, a lot of times they don't get better. Maybe they don't have the strong enough steroid that they need, or they don't have the proper dosage of the medication. I think they tend to get on the right track sometimes, but sometimes they don't. I want to talk about, we're going to kind of focus now on a special aspect that's really pertinent to those that are listening here. It's going to be about melanomas and different types of skin cancers, basal cell cancer. And that's what I like to focus on, because you mentioned to me that's one of your areas of interest and kind of passion that you have, right?
Yes.
How did you get passionate about that? Why? Have you had some experiences with certain patients? Any stories you have?
Sure. Well, it's probably the most common thing we see patients for, the most common thing coming in, a lesion that has changed or maybe is newer, that they're concerned maybe skin cancer. And I think it's good that the awareness is out because, as you know, most of skin cancer is related to sun exposure. So it's good to know that, you know, people are wearing more sunscreen and are more aware in general of their skin and their changing molds and are coming in for that. But we just see a ton of it on a daily basis, and probably on an average day in my office, I see at least 5.
Really?
Yes, yes.
Okay, so let's kind of keep it simple for those that are watching.
Sure.
We're going to first show a picture here of some skin cancer.
Sure.
What are people going to look for when they look at their skin? How do they know they need to see you? What are they looking for? What is this picture showing?
Great question. So the first slide here shows a basal cell skin cancer. There are 3 main types, but the basal cell skin cancer is actually the most common type of skin cancer there is. There is a statistic that maybe 1 in 5 Americans in their lifetime will develop skin cancer, despite all the awareness and the protection that we're using. And this is the most sun-related type of skin cancer there is. Having said that, while cancer can be a scary word, the basal type is very slowly growing. People can pick up on skin cancer, this particular type, by the pearliness of it. If you see here in this picture, it kind of has a pearly sheen to it. It's more of a bump on the skin. Sometimes in later stages, it can crust over. It may come and go. It's newer, but because it grows slowly, it can kind of come and go over several years before patients come in.
Is it a uniform color, or does it have different kind of shades?
So usually a pearly translucent type color to it in the initial stages. And as it progresses down into the skin, it can become eroded. So it can look like an open sore or a pimple. So anything that is not healing or is newer or is coming and going can be a sign of basal cell skin cancer.
Where would you find this? Is it normally on the face, on sun-exposed areas mostly?
Good question. And so we mentioned that it's sun-related, so you expect to see it on sun-exposed areas. I find most of my basal cell skin cancers actually on the face. Probably secondarily, second would be on the arms, the extremities, and then the chest or back. Areas that maybe you go to the beach and you're not wearing a shirt. As we know, you should really wear sunscreen all day long, and even in the winter when you're outside. A lot of it is from incidental sun exposure. So people are, for example, driving in the car
have their arm out the window,
not realize that UV light that can lead to sunscreen is coming in. So basal cell, again, while very common, is easily cured, but is locally destructive. So the pearliness, the white hue to it, a bump that's kind of coming and going, something that you think may be an acne lesion, but it's not going away. Any of those things you need to come in for.
So let's talk about, let's say someone does come in for something that you think it might be this type of a cancer. What's the first step? Do you look at it and say, okay, we can remove that? Or do you say, let's biopsy it first? Do you do a shave or a punch? Or what type of biopsy do you do on that?
Yeah, so usually for basal cells, we can clinically diagnose most of these. We do like to confirm, though, with a shave biopsy, which we simply take a small shave, scraping of the lesion in the office and send it to the lab for confirmation.
Not taking the whole thing out, just a little bit of the
Just
top.
a little sample of it,
Okay.
so a biopsy. And I usually will tell patients prior to taking that sample that, my thought is that it could be a basal cell skin cancer, so that they're prepared, when I do call within a week with the results. And we sometimes talk about the steps that are necessary for treating that basal cell.
And we can talk a little bit about treatment. So let's say it comes back, they get the biopsy report, and you've prepared them. Okay, it's one of the better types of cancer, I guess you could say, to have. What's the next step?
So usually basal cell, the treatment will depend on the location. So if it's on the face, usually we refer to a plastic surgeon or a Mohs surgeon. So the plastic surgeon will then go ahead and remove the skin cancer. It may take some normal skin surrounding it to make sure that everything is gone, both on the wide margin and also on the deeper margin of the lesion. And they do a very good job with closure. Also, it's great when people come in sooner than later, because then that will determine the size of the scar. So the smaller the basal cell, the smaller the scar. For more extensive basal cell skin cancers, or those located on, for example, on the nose, an area where there's not a whole lot of skin to move, we do refer to a Mohs surgeon. And a Mohs surgeon, or the Mohs procedure, basically involves going into someone who has undergone additional training. A dermatologist has undergone additional training. And they remove the skin cancer in layers. And then while you're waiting, they will look under the microscope to see if all the margins are clear, if all the skin cancer is gone before they close up.
Yeah, and we have, I'm sure people that are listening, they've heard of, they've had this type of a procedure. And it's a very effective procedure. It's pretty much the standard of care for these types of areas.
Absolutely.
Kind of
they
takes
do
a
wonderful
while.
job. But it's worth it to know with confidence. Say you have a larger basal cell on the nose, you know that, hey, it's pretty much gone by the time they close up, as opposed to thinking it's gone, and unfortunately then the pathology comes back that maybe there is still some there, and then you have to go back for additional treatment.
Well, that's what I was going to ask. How often is it to have basal cell in two different areas, or to have basal cell come back?
So if you have Mohs surgery, the risk of recurrence in that same area is very, very, very low. Most of the surgeons, if not all, who remove skin cancer will send it to the lab, so the likelihood of recurrence in that particular area is low. Sometimes with very superficial basal cell skin cancers, because they're more surface higher on the skin, we may also prescribe a topical cream, to treat that area. In that circumstance, sometimes the risk of recurrence may be slightly higher than in surgical procedures.
Is it one of those creams that kind of exfoliates the top layers of the skin? Is that what it is?
It, because the skin cancer is so early and just so superficial on the skin, a cream is all that you need. Another procedure for superficial basal cells is where we scrape away the skin cancer and then destroy the remaining cells with electric current. So sometimes we use that procedure as well.
Is that called cautery?
Electrodesiccation and cautery, or ED&C for short.
Done in the office?
It's done in the office, fairly quick, very, very effective for certain basal cell skin cancers. And again, the recurrence rate, while it's slightly higher than, say, with Mohs or traditional removal by a plastic surgeon, it's low.
Okay, good. So that's basal cell. Is there is that the main one that you see, or are there another couple of other types?
That's the most common type of skin cancer. So the next common type, slightly more aggressive, is called squamous cell skin cancer.
So we're going to show you a picture here of a squamous cell cancer. And explain a little bit what we're showing the
So the way to identify a squamous cell skin cancer is if you have a scaly, red, patchy area on the skin. Some people may assume that it's a psoriasis lesion or maybe that their eczema has come back. But again, if it doesn't respond to treatment or is progressive, that's something that you'd want to come in and have checked.
Okay.
Usually, again, on sun-exposed areas. So the face, the arms, the chest, the back, and sometimes the legs, because people do like to wear shorts, you know, especially in the summer.
Any difference between lighter complexion and darker complexion in terms of seeing these lesions?
Yes, good question. So in general, I would say that obviously the lighter your skin, the more common, the increased risk there is for skin cancer.
Okay.
Most of the skin cancer is found in people of lighter complexions.
Okay.
You know, people who burn in particular are at highest risk. Having said that, it doesn't mean that in darker skin patients that, you know, we don't look for skin cancer. It just doesn't happen as commonly. And more recently, the statistics show that in darker skinned populations, while the incidence of skin cancer is lower, they're usually found at more advanced stages.
Because they delay in getting diagnosed.
That's correct, or the awareness is just not there. So we like to encourage everyone to take precautions, and if there's anything that is acting oddly, strangely, is not going away, to come in and have it checked.
Okay, good, good. And then next, is it they come in, it's the biopsy and then removal, or is there any other different types of treatments for this squamous cell?
So the squamous cell can be slightly more aggressive. And this one, actually, certain subtypes of squamous cell skin cancer can occur very rapidly.
Now, do you mean rapidly? I know there's a word that some of the audience may know, like metastases. Is that what you mean, rapidly, or just grows quicker?
Just grows quicker, and usually is more painful than a basal cell that is usually painless. And like I said, this is your red scabby type lesion, or sometimes you can have a form of squamous cell that looks almost like a crater, like a volcano. It's heaped up and has the center has a little bit of a scab to it.
Yeah, and then so what's the treatment? If it's more aggressive, is it more aggressive treatment then, since it's more aggressive?
Well, even with squamous cell, while I say slightly more aggressive, usually we find this very, very early.
Okay.
Patients come in because it's growing
painful,
rapidly,
or
it's
it's painful.
painful, that's correct, or it bleeds. And so most of the squamous cell skin cancers that we find are relatively early.
Good.
And so again, while the risk of metastasizing or spreading to other sites of the body is slightly higher than with basal cell, relatively it's much lower than, say, with melanoma.
Because you catch it sooner.
That's correct.
Catch it sooner. And then you'll do a similar Mohs procedure or scraping?
Depends again on the location of the skin cancer. Excision usually is the mainstay where we remove the skin cancer, making sure that we get everything
extra skin
that's
inside.
right, surrounding and also deep.
Good. So that's the second type. Is there a
That's
third
right.
type, or are those the main two?
The third type is melanoma.
Okay, a regular melanoma. I think people have heard that word. I think if
Sure.
you're listening to this, you've heard of the word melanoma.
Sure.
Think of a black, kind of a dark
Yes,
lesion.
that's right. And this can be the deadliest form of skin cancer. Having said that, when caught early, the prognosis is excellent.
Okay.
Most melanomas start off either in an existing mole
I was going to
that
say,
has
usually people
changed.
think of this as a mole. Oh, my mole has always been there since I was born, or a
That's
birthmark,
right.
or things like that.
So it can form within an existing mole. So just because a mole has been there for 20 years, in that 21st year, if it starts to change, then you need to have it checked. Or it can arise as a new mole. So any new moles or moles that are changing, you'd want to have checked out. We talk about the ABCDs of melanoma. So very briefly, A stands for...
Show a slide.
Yes, a slide of one. A stands for asymmetry. So you want to draw an imaginary line down the center of the mole, and you want to look to make sure that the left side matches the right side. B stands for border. You want to make sure the borders are nice and sharp and crisp. And so if they're fuzzy or scalloped in any way, that can be a sign of melanoma. C stands for color. The color has to be uniform throughout. If there are shades of black or brown or reds, that can sometimes be a sign of melanoma. And D is diameter. Anything that's growing or changing rapidly. Usually we say moles over the 6 millimeter size. You want to be careful of, but I've found melanomas much smaller. So anything that's growing, you want to be aware of.
And if someone, typically these types of patients, they would have not just one, they would have probably multiple moles on their body.
That's correct.
And they would come in, or ideally they should have a skin check, right? If someone has a lot of moles, maybe a skin check once a year, is it, or how often do they come in?
Yes, I would say in general, if you have more than 50 moles on
50?
your body, on average, you probably do want to come in and have a skin check on a yearly basis. Or if you have a family history of melanoma, first degree relative, you'd want to come in and have your skin checked regularly. If you're fair-skinned and you burn, you know, or have had a history of several sunburns growing up, if you like tanning beds, any of these things you should come in, because those are the risk factors for developing skin cancer, and in terms of the number of moles and family history specifically for melanoma.
Okay. Someone comes in, they have kind of this little dark mole, they think it's a mole or something, maybe it itches, then you would do a biopsy. Is that what you would do? Is it a shave again? Is that what you would do? Or can you tell just by looking at it?
So good question. For melanoma, most of the melanoma we find have dark pigments, so they're darker moles. There are there's a very rare subset of melanoma where it can be pink or red. It's called amelanotic, or without melanin or without pigment. But that's much, much rarer. Most of the melanoma we find have these dark, varied pigments within the mole. And yes, we would try to do a deeper biopsy usually. So we would do what's called a punch biopsy, where we go through more layers of skin, because the way that melanoma is staged depends on the thickness of that melanoma.
The depth of it.
That's right. So we want to make sure that we get all the layers of skin when we're doing a biopsy. If we are going to do a shave, we'll do a much deeper shave, or sometimes a punch, or sometimes trying to remove the entire mole via an excision if the degree of suspicion is high.
Okay. And if it comes back, in terms of, we don't want to go into the details of the staging.
Sure.
Some stages, the less deep it is, the better the prognosis or the better results for the patient.
That's correct. In general, with any type of skin cancer, the earlier it is found, the more superficial, the better the prognosis. And so melanoma can, again, scary word, but if you have a superficial melanoma that has not invaded that second layer of skin, the prognosis is excellent. That buys you very frequent skin checks, at least every 6 months, I would say. Absolutely, depending on the stage. And the treatments for melanoma have gotten so much better, even for the deeper or the later stage melanomas.
Is it topical or is it surgical, or what are the treatments for the melanoma?
So usually with melanoma, it's always surgical, because, you know, it can be such an aggressive skin cancer. It can spread to, you know, distant lymph nodes and other organs, that we want to make sure that we get everything. So without fail, usually we do a much larger excision for melanoma, making sure that we have a lot of normal skin around, and we send that to the lab to test it to make sure that everything's gone.
And do you evaluate those lymph nodes as well at the same time?
We do. With my patients with a history of melanoma, every time they come in, we do feel those nodes to make sure. And if the melanoma is a little deeper than the top layer of skin, usually then we have them see an oncologist to make sure that they're well scanned and taken care of and followed.
Okay. So those are the top 3 types of melanomas, and probably the most frequent ones. What I'd like to do as we kind of conclude our talk today is talk about kind of sunscreen.
Absolutely.
Let's say you do find one and it's taken care of. You have the skin checks, but what else can you do? And just kind of preventing them from happening. If you've never had one, how do you prevent one from happening?
So this is a really, really important part of skin cancer prevention. So in this next slide, we're going to see some sunscreen, a picture of sunscreen, and what we should look out for with our sunscreen. So here you're going to look for at least an SPF of number 30 or above. The SPF number refers to the protection that you're going to get in terms of UVB light exposure. But now we know that UV...
I'm sorry, what's UVB?
Sure, sorry. Ultraviolet light that comes from the sun. There are 2 main types. There's A, B, and C. So the SPF number refers to how much you're protected from the UVB light. The UVB light, before more recent research was done, was found to cause most of the skin cancer. But oddly enough, we have also found that UVA light can also cause skin cancer. So when you're looking at a bottle of sunscreen and you see that SPF number that says 30, 50,
Okay.
even 100,
Yeah.
it's only protecting against one form
The UVB.
of ultraviolet light, the UVB. So now it's really important to read those bottles because we also want to be protected against the UVA light. So we're going to look for a label that says broad spectrum.
Okay.
That means it protects not only against the UVB light, but the UVA light. Because recent studies have shown that UVA light, ultraviolet A, that comes from the sun can also lead to skin cancer.
Okay.
And it's important to know that UVA light can come through the windows. It can come through the windshields when you're
Really?
driving,
Okay.
right? So this is why it's so important to always wear sunscreen on sun-exposed areas, even when you're driving, because we know that over time, UVA light can also lead to skin cancer.
Wow. Okay.
All
That's
right.
pretty-
So broad spectrum
Okay.
means UVA protection and UVB protection.
Okay.
Okay.
Yeah.
So that has to be on the label. You want to make sure that the UVB protection in the SPF number is at least a 30 to 50.
Okay.
You also want to make sure that you reapply that sunscreen every 2 hours.
Really?
Absolutely. Every 2 hours. No matter if you pay $5 for a bottle of sunscreen versus
$30.
$50
Yeah, $50.
for
Every 2 hours.
Every 2 hours because it degrades on the skin.
Really?
Yes, so it's really important to make sure you reapply every 2 hours. Okay.
So I'm not going to let my wife watch this.
Oh my.
Because when we were engaged, she got me this Neutrogena SPF 30. She said, you have to wear this every day. And I'm like, what? Every day? I don't, men, we don't put a lot of things on.
Sure.
But okay,
It's
every 2
important,
hours, great.
everybody,
Perfect.
and even people of color, darker skin
Every
types.
2
I think
hours.
the culture is that, we're not used to wearing sunscreen,
Yeah.
but it's important. Everybody needs it. When I go to the beach, I put it on.
And
I
how
have
about
it on
swimming?
right
Is it
now.
after you swim you should do it too? Or how
Sure.
about the waterproof ones?
Good question. There is no such thing as waterproof. There may be water resistant, but it's really important after you come out the water to reapply that sunscreen as well. It's really important. You want to use about, if you imagine a shot glass full of sunscreen for your entire body if you're going to the beach.
Wow.
Yes, you want
Okay.
to just make sure
Good.
that you
Well,
have
I'm-
enough
I'm
on.
gonna change my
so you're well
ways.
protected. Another common question I get is it okay to use a spray type sunscreen? And while
have
my
the spray.
preference, while my preference would be a cream or a lotion, if you do have the spray, it's better than nothing.
Okay.
But after you spray it, then go ahead and rub it in, okay? Because a lot of it gets lost in the air, in the
Yeah,
atmosphere when you're spraying it. So you have to come back in, rub it in.
Yeah.
That's very important.
Wonderful. Any other quick tips for those that are watching about protecting against skin cancer?
Hats, usually wide brimmed is my preference because that gets more protection around the ears and the neck. Closer weaved clothing. A lot of the clothing nowadays
The
will
transparent or
say,
see-through.
UV protection base, but you want to make sure that the weave, is tight, that you don't have a lot of gaps in that fabric that will allow the sun to come through. And sunglasses, because we also have pigment in the back of our eyes, so we want to make sure that our sunglasses say UV protection as well.
Wow.
And for you, because I know you're a podiatrist,
Yeah,
you want to
yeah.
make sure.
Put on your feet.
That's right.
Yes.
Yes, because lots of people wear sandals and flip-flops in the summer and forget about the tops of their feet.
Yeah, we get 'em
So we have to
burnt
make
in.
sure that we put the sunscreen there as
Great.
well. Avoid the tanning booths. There's a study that shows that if you go tanning, it increases your risk of developing melanoma specifically by 59%.
Wow.
So the tanning boost is the same thing as, being in the sun. They use ultraviolet light, and we talked about how dangerous that can be
Yeah,
and lead to
yeah.
skin cancer. So avoiding tanning is really important as well. Sitting in the shade versus sitting outside.
So common sense things.
Yes, common sense things. And there was also a study that recently said taking vitamin B3 or nicotinamide can also be very helpful in preventing skin cancer. So it's vitamin B3. It's available. You don't want to get the niacin though, because that will cause flushing. You want to get nicotinamide in 500 milligrams twice a day. In a recent study in JAMA, which is one of the more well-renowned medical journals, showed that it offered great protection against the sun. So these are little things that you want to do. avoid smoking. You know, that affects almost every organ system, including your skin, and may
Wouldn't
increase
have
your
thought about
risk
that,
of,
yeah.
you know, skin cancer. So these are little things that you can do to protect your skin and avoid skin cancer.
Oh, great. Oh, great. Dr. Roberts, thank you so much for being on the show.
Pleasure.
Really, I think we've all learned a lot more about skin cancer and how to avoid it, and you've got some great tips here. Once again, Camille Roberts from as a dermatologist in the Worcester area.